Good morning and welcome everyone to this week's APSAD Insight webinar. My name is James Hoey. I'm one of the clinical educators here with Insight. I'd like to begin today by acknowledging the traditional owners of the lands on which we're meeting and pay my respects to elders past, present and emerging. And I'd also like to extend that welcome and respect to any Aboriginal and Torres Strait Islander people who are joining us here in the room at Byalla today in Brisbane, or who are out there in webinar land. It's going to be my pleasure this morning to introduce to you Dr. Lexine Stapinski, who comes to us from the Matilda, who is the Senior Research Fellow from the Matilda Centre for Research in Mental Health and Substance Use, which is part of the University of Sydney. And Dr. Stapinski today is going to be speaking to us on the link between alcohol, anxiety and alcohol use and the implications for treatment and early intervention. Something that I know myself I'm really looking forward to, given that for any of us who work in the field, it doesn't take too long to understand that there's a significant association between those two conditions. And anything that we can learn about ways to both treat and or prevent, I think is especially important. So Lexine, if it's okay, I'll hand over to you. I probably, should also, before we do that, just let you know for all our attendees today, if you do have any questions, feel free to pop those in the chat. We'll try and curate and collate those and have an opportunity for question and answer before we finish up today. I do apologise in advance if we don't get through all of those. And also just to let you know that there will be a copy of the presentation from today, but it won't be available today. It'll become available when we post the recording up on the Insight website within the next week or so. So it'll be downloadable for there. So yes, so without any further ado, I welcome you, Lexine. Thank you very much for kindly joining us today. And we look forward to your presentation. Thank you.
Thank you so much, James. It's great to be here talking to you all today and about a topic that's very close to my heart. And as James said, I guess it's something that I suspect many of you will have seen in clinical practice as well. And I'd just also like to acknowledge, though, the traditional custodians of country throughout Australia. I'm on Darawal land at the moment, but I'd also like to pay respects to the traditional custodians where you are today. So in terms of what I'm going to cover, I'm going to start out by talking about the evidence for this link between anxiety and alcohol use, and also why it is important for us to think about clinically. I'm then going to talk about what we know about which treatments are most effective for people that have both alcohol and anxiety problems. And then I'm going to kind of wind back the clock a little bit and have a look at whether we can intervene earlier in the life course to prevent escalation of anxiety and alcohol use problems. So I know most of you are probably working primarily in drug and alcohol fields. So just a quick little background about anxiety. We know obviously that this is a very normal human emotion, a very common and helpful reaction, but for some people it goes into overdrive. And that at the other end of the continuum, it can be a really disabling disorder with just a huge impact on a person's social functioning, their work and their quality of life. And the most recent national data that we have indicates that 1 in 6 Australians will be affected by an anxiety disorder in a 12-month period. And when we're talking about anxiety, we're usually talking about 3 core components that make up the experience of anxiety. So there's the things that go on in the body. This could be heart pounding, dizziness, shakiness. There's the thoughts that people have. This can be worries. Often there's an exaggerated perception of threat. So the impression that it's very likely that things are going to go wrong. And then of course behaviour. And what we see really commonly in anxiety is that avoidance behaviour. So both avoiding situations, but also implementing safety behaviours as a way of coping or reducing anxiety. And we'll talk more about this as we go on, because alcohol might be one of the ways that people do this in the case of anxiety. Types of anxiety that I'll be mostly talking about, or that I'll be focusing on today, are social anxiety disorder, so where we're really talking about that core social threat that people will have. A panic disorder, where people can have both a physical and mental threat, so concerns about having a heart attack or losing control, going crazy. And then generalized anxiety disorder, where we've got, basically just worry about lots of different areas, fears about not being able to control worry, or meeting responsibilities, letting other people down, those kind of things. And so in terms of our big question then, whether there's a link between anxiety and alcohol use. So we know that in Australia, we've got a lifetime prevalence of alcohol use disorder of about 22%. And then what Smith and Randall have done in their research is looked at the relationship between different types of anxiety disorders and alcohol use disorders. So across a number of different studies in a number of different countries. And what they've concluded is that kind of across the different anxiety disorders, there's about anxiety is linked to about 2 to 3 times greater risk of having an alcohol use disorder. And so what you can see in practice is this means in Australia, we see that 1 in 3 people with a substance use disorder also has an anxiety disorder. So James mentioned at the beginning that it's pretty common for people that you might be seeing in practice to have anxiety, and indeed the data also reflects that is the case. So how do we understand this relationship between anxiety and alcohol use? One of the models that's been proposed is that the anxiety use disorder precedes and gives rise to the alcohol use disorder. And so this is the idea that alcohol has either a perceived or real anxiety reducing benefit. And so people with anxiety disorders can come to use alcohol in an attempt to cope with their anxiety, or reduce their anxiety. And in support of this idea, what we do see is that the onset of anxiety disorders typically precedes the onset of alcohol use disorders. And we also see in the research that reports of drinking to cope have been identified as a risk factor for subsequent development of alcohol use disorders. A second, though, explanation for why we might see the relationship is that the alcohol use disorder may, in fact, induce anxiety. So when a person is withdrawing from alcohol, certainly we see there is an increase in anxiety symptoms, and it's thought that prolonged use of alcohol may disrupt the stress response system. And so consistent with this idea that the alcohol use may actually cause the anxiety, we do see that for some anxiety problems, so particularly GAD, if you stop drinking, if a person stops drinking, then their anxiety does improve over time. However, it's estimated that at most, this only explains 25% of cases because of that order of onset, because anxiety is far more common to occur before the alcohol use disorder. And also it should be said that there are other anxiety disorders, so such as social anxiety, which really don't tend to improve even after a period of alcohol abstinence. So it might be different for different disorders. And then finally, of course, there is the explanation that there might be a third variable, so other factors such as genetic, socio-demographic or personality factors that represent a common vulnerability for both the disorders, both anxiety and alcohol use disorders. And so this might explain why they occur at a higher rate. But in any case, once these problems begin, it's likely that they fuel each other in a vicious feed-forward cycle. So the vicious cycle model presented by Stewart and Conrad is one way that we can understand this relationship between anxiety and alcohol use problems. And from this framework, the tendency to self-medicate with alcohol can lead over time to an increasing reliance on alcohol to cope with anxiety, stress, and other emotions. And as you become more reliant, of course, this leads to more drinking. And what we see is that when drinking levels increase, so does the risk of developing alcohol dependence, but also a range of potential problems that are associated with drinking at that level. And so what we can see then is because of those problems, because of that reliance on alcohol to cope, alcohol can in turn exacerbate anxiety symptoms. So both through those withdrawal effects, but those associated kind of life impacts. And so what we can see is there can develop this vicious cycle between the two problems, which perpetuates each, but also makes recovery more difficult. So just to illustrate, I thought I would share two case examples that illustrate the relationship. These examples come from work that we've done in treating co-occurring anxiety and alcohol use, but they've been adapted to protect confidentiality. They don't represent one single client. They're adapted from multiple different experiences that we see in practice. So first of all, Claire. So Claire is in her early 40s, married with one daughter. Her anxiety is really around performance. So she's highly perfectionistic, has really high standards, concerned about being perceived as incompetent, even though she's very good at her highly demanding job. And for her, she's really drinking alcohol to unwind at the end of the day, to forget about her stress and forget about her worries. But it's escalated over time and has increased to 1 to 2 bottles of wine daily. And then in terms of that vicious cycle, we really saw with Claire that there was a rebound anxiety effect. So the next day, of course, she felt pretty rubbish about herself. She felt, some of the physical symptoms of hangover, but also of withdrawal and of anxiety and stress the next day. And she was embarrassed about her drinking and worried about the impact on her daughter. So really that kind of vicious cycle between the two problems was evident. Now, the second case, and this is another presentation quite typical of what we see, is Luke, who's in his late 20s, lives alone, and his anxiety is really focused around social interactions, and particularly social interactions with women. And a lot of the reasons for his drinking relate to drinking in advance to manage anxiety at social events. So he would drink 16 plus drinks when he's out on the weekends. But his drinking also had expanded to other nights as well. So at home, there was this kind of drinking around drinking in response to low mood, feeling hopeless about the fact that he's not able to form romantic attachments. And again, we saw some rebound effects where he would feel, after a night of drinking, he would often feel embarrassed about what he might have said. He wouldn't be able to remember everything clearly, so he'd feel embarrassed about the potential social faux pas that he might have made. So I'll come back to these case vignettes in a little while as I talk more about treatment. So why is it important clinically to think about this relationship? Well, we know that when people have both anxiety and alcohol use problems, their problems tend to be more debilitating and more chronic. But also because of the fact that the problems fuel each other, we see that people with both disorders don't respond as well to standard treatments. And there might be a number of different reasons for this. First of all, the dual presentation might impact their ability to engage with treatment. So for a person with social anxiety, going along to a group treatment or facing up at a clinic at all can be very difficult. But also we know that the anxiety symptoms are going to be one of the strong triggers for drinking. And so indeed the research shows that anxiety symptoms are among the strongest predictors of relapse and non-response to treatment. So I just put here a few measures that might be useful in terms of asking about anxiety, a few screeners that we found useful in practice because when we're seeing these high rates of comorbidity, it is important that we're asking drug and alcohol clients about their anxiety because they may well be experiencing clinically significant anxiety. And then, of course, when we're asking about alcohol use, it's important to be thinking about the motivations that a client might have that are related to their anxiety. So exploring their reasons, their ambivalence, of course, but also their reasons for use, which may include managing their anxiety. And often what we see is there can be unrealistic positive expectations that a person can have. So in terms of the idea that alcohol is helping them socially, perhaps making them feel more confident, helping them feel sexy, helping them perform better or be more talkative. And so it can be useful along the course of therapy to kind of shine a light on those beliefs, but also evaluate them critically against the reality of what actually happens. And we saw that with Luke, that in fact his drinking doesn't really help him perform better socially. In fact, it might be quite the opposite. And I'd recommend the alcohol expectancies questionnaire is a nice kind of way to have a look at some of the different beliefs that people might have about how alcohol is helping them with their anxiety. But so coming back to Claire and Luke, what we really saw in terms of reasons for use, that for Claire, alcohol was helping her unwind. She also had beliefs that she deserved to relax, but her motivations were to change were that flip side, the embarrassment, the shame, and the impact on her daughter. And then for Luke, his reasons to use were that he felt more confident, that it helped him talk to women. He felt unable to talk to women without alcohol, but he wanted to change because he felt embarrassed about looking like an alcoholic or fearing, in fact, that he might be, and he didn't want to use it as a crutch. So, coming now to our second question about the effective treatment approaches for co-occurring problems. And for people with these co-occurring anxiety and substance use problems, the services tend to be set up such that some services specialise in treatment of substance use while others specialise in the treatment of anxiety. So it often means having to choose. And this means that people with both problems can get stuck on a what we call a comorbidity roundabout, where they're being referred on from one service to another because of their dual problem presentation. So as I mentioned before, in some cases, anxiety does remit when people stop drinking for a little while. So it's often been the case that patients are recommended to work on stopping their drinking first. And, you know, on some levels, this makes sense, as we also know there are cognitive impacts of alcohol use. So reducing or stopping use is going to mean a clearer head, you know, to engage with treatment. But the problem is that cutting back can be really difficult for people with co-occurring disorders. And as I mentioned before, anxiety is one of the strongest predictors of non-response and relapse. So a really important question is whether it would be better to treat these problems together. And the reason to do this would be, well, firstly, that we know people don't respond as well to standard treatment approaches, but also that it sort of fits with how people are experiencing these problems. They often see the problems as being interrelated. So in some research that we did funded by the NHMRC, we looked specifically at this question in relation to co-occurring social anxiety and alcohol use disorders. And social anxiety is a common presentation to co-occur with alcohol use, which makes sense given the pervasive availability of alcohol in social contexts. And so in the case of social anxiety and alcohol use, there had been 2 previous trials that had looked at the question of whether it was better to treat the 2 problems together. So the first one by Sade and colleagues was treating the problem sequentially. So first they were treated for alcohol and then they were treated for anxiety. And the second trial by Randall and colleagues was offering 2 parallel treatments. So 2 different psychologists at 2 different locations, one of them who provided CBT for alcohol and one who provided CBT for social anxiety. Now, the SHAD-A trial found benefits for anxiety only, so there were some advantages. However, the Randall trial actually found that there was worse outcomes when you tried to offer these dual treatments. So the people that got both CBT for alcohol and CBT for social anxiety had worse alcohol outcomes than if you just delivered alcohol treatment only. And they attributed these worse outcomes. Obviously, it was disappointing, not what they were hoping to see, and they attributed to it a number of different factors. They thought, first of all, that it might be due to that coping mechanism of drinking to cope with anxiety. So if people were working on their anxiety, they were putting themselves in situations where they were more likely to experience anxiety, and then this might have led to an increased need to drink, or increased tendency to drink. But the second thing that they acknowledged was that it could be quite confusing and have quite overwhelming for clients to have both 2 different treatments from 2 different psychologists. And really in this trial, the onus was on the client to integrate the techniques that they were learning. So that was the second explanation that they gave, that it might have been confusing and meant that people didn't benefit as much. So I guess a take-home message from that is that it's really important that it's us that integrates the treatment and the strategies for clients, rather than relying on them to do it for themselves. And so this is what we did in our trial. We took evidence-based, the most supported evidence-based approaches for social anxiety and for alcohol use. So for alcohol use, this included motivational enhancement as well as CBT strategies. And then when we were integrating the techniques that are that you would apply to both social anxiety and alcohol use into the one package, into the one 10-session package. So as I mentioned, it incorporated both motivational enhancement and CBT, and the skills were developed so that all of the skills involved were applying we were working with clients to apply these skills to both social anxiety, to alcohol use, and to manage the interconnections between the 2 disorders. So I'll walk you through each of these components. So first of all, the whole program was embedded within a motivational framework, enhancing people's motivation to and empowering them to make changes. Particularly in the initial sessions, we really focused on that. We focused on alcohol, trying to get some initial gains in terms of reducing alcohol use to kind of relieve some of the chaos that might be surrounding the person, but also getting them into a position where they were able to cognitively benefit from the treatment program. And the goal setting, because it was embedded in this motivational framework, goal setting was really driven by the patients. But we did prefer a goal of abstinence, at least initially, for the first month, if clients were willing to aim for that, in order to build some momentum and begin to reduce their dependence on alcohol. But as I said, it was really goals, it was from a motivational framework, so goals were set collaboratively rather than imposed on clients. So in those early sessions, we were also working with clients to build coping skills to manage the triggers for drinking and anxiety, and to enhance their social support networks, which is really important, knowing that these are people with social anxiety who may not have good social networks, but also that often friendships can be drinking buddies. Friendships can revolve around alcohol. So really trying to focus on building up sober, positive relationships that the person might have. Often people's activities, interests and friendships had come to revolve around drinking, and so the client was also supported to engage with other interests and develop new interests. And then importantly, early on in the sessions, we were working with clients to help them manage the thinking processes that contribute to anxiety and drinking. So in the case of social anxiety, people tend to expect negative consequences and outcomes in social situations. So we would work with them to critically identify first and then critically evaluate these cognitions. But the cognitive work would also include looking at the thinking processes that contribute to drinking as well as uncovering some of the thinking that might drive the interrelationship between social anxiety and alcohol. So such as those positive beliefs that I talked about earlier, that alcohol makes me more interesting or helps me perform better socially. So really shining a light on those and looking critically at how they aligned with the actual reality of what was happening for people in situations. And then behavioural experiments or exposure are a really important part of treatment for social anxiety. So addressing the avoidance that people have developed over the years of many different types, often of social situations, and building them up gradually to practice, to face these situations and practice new coping strategies. And just to mention that this approach is in contrast to some other alcohol treatment approaches, which might encourage avoidance of any cues that might trigger drinking. So in our program, people might have initially avoided some high-risk situations, such as going to a bar, because they weren't yet feeling equipped to cope with those, but they would be encouraged to slowly build up their capacity to handle social situations and triggers for anxiety without alcohol, so over the course of the treatment program. So it was really an approach-focused treatment rather than encouraging people to avoid things that might be risky. Then finally, we know that in the case of social anxiety, there are attention processes that contribute to the disorder. So we worked on helping people to reduce their hypervigilance for social cues, negative social cues, and also providing some techniques to help people disengage from sticky, repetitive thought cycles that might contribute to their anxiety and drinking. And then finally, towards the end of treatment, we worked with clients on relapse prevention, how they might deal with setbacks and continue change. So in our randomized controlled trial, what we wanted to see was whether the integrated treatment could improve outcomes for patients who were diagnosed with both social anxiety and alcohol use disorder. And so we recruited 117 participants to the trial, and just quickly, some of our exclusion criteria included active suicide risk, psychosis, or dependence on illicit drugs. So really wanting to focus in this trial just on the alcohol use. And so participants were randomized to either receive the integrated treatment package that I talked about before, or or a treatment package which was the same number of sessions, so both 10 sessions, but the other treatment package was focused exclusively on alcohol. And so I've gone through the integrated treatment package. This was, as I said, 10 sessions, but all delivered by clinical psychologists who'd received training, but they didn't have specialist experience in treating comorbidity. And then the comparison package also included both CBT and motivational interviewing, but it was exclusively focused on helping people manage their alcohol use. And it was delivered by the same group of therapists. So our primary outcomes that we were wanting to look at was social anxiety symptoms, how they reduced in terms of their drinking and their dependence, but also their overall functioning and quality of life. And just to mention that participants also, given they did have, in many cases, very severe alcohol use dependence, they also had the option of pharmacotherapy to support them in both conditions to support their alcohol use reduction. So our completion rates were higher in the integrated treatment, so 70% completed treatment compared to 64%. And we followed them up immediately after treatment, as well as 3 months and 6 months later. And we had reasonably good follow-up rates between about, well, the lowest, about 65% to up to 80% at post-treatment. And I believe it was something like 85% of our participants completed at least one follow-up. So we have some data from most people. Okay, so skipping through because I know we've got some time to catch up on. In terms of the results, so the analyses were all intention to treat, and these use multi-level mixed models for repeated measures, and we modelled missing data using FIML. And in terms of our social anxiety symptoms, what we saw was that pretty clearly here in the blue, we see that the integrated treatment clearly was beneficial in terms of people's social anxiety symptoms. There were significantly greater reductions at all 3 time points. But coming now to the alcohol consumption and severity of dependence, what we saw here was that both groups were able to make really quite big changes in terms of their alcohol consumption and also their severity of dependence. There weren't any differences between groups. So the groups were able to make equivalent changes in terms of their alcohol use and dependence symptoms. And I find this really interesting because the groups were doing really different things. In the integrated treatment group, they were being actively encouraged to reduce their social avoidance. So the people in that condition were going out, they're attending parties, they're attending social events and activities. And these are people that in the past tended to medicate their social anxiety by using alcohol. So what we see here was that they were managing to engage with social events and activities while at the same time reducing their drinking. And so we're really pleased to see that, but we didn't see that they reduced their drinking more than those that were just focusing on alcohol treatment. And then finally, what we see in terms of the overall impact for people is that those that got the integrated treatment had improved quality of life, and they also had improved symptoms of depression as well. So there were kind of broader impacts for the people who had received the integrated treatment. So in conclusion, should we treat social anxiety and alcohol use together? What we saw in our trial was that with the same number of treatment sessions delivered by the same pool of psychologists, the integrated treatment led to better social anxiety outcomes, led to equivalent reductions in alcohol consumption. It led to better overall functioning and quality of life, lower depression. And I guess also one thing that I really reflected on was that people that we talked to in treatment, they really did see their anxiety and alcohol use as interrelated. So it seemed that the integrated treatment was a better fit with the person's experience because it explicitly addressed the interconnection between the two problems. So just coming back to our case examples in terms of how the treatment played out for them, one of the biggest things for Claire was getting her out of her strong evening routine of pouring a glass of wine as soon as she walked in the door. So replacement with an alternative drink she found really helpful. The cognitive therapy component was also very important for her, both to challenge her cognitions, the cognitions driving her anxiety, but also challenging the positive beliefs that she had about alcohol helping her to relax. And for her, there was this strong idea that she deserved to have a drink. And so that was one that we could actually examine cognitively. Reducing her alcohol use actually had a big impact on her anxiety. She found that she woke up feeling really different and was much more motivated to get organised in the morning and over the day, and it meant she was less irritable and stressed. And so she sort of saw immediate results of reducing her alcohol use, which helped her in terms of gaining momentum and making additional changes. And she was also less worried about her daughter and the impact on her. So for Luke found that if he didn't buy alcohol, he was disinclined to leave the house once he got home. So that was a good strategy for him. We focused on building up his confidence in social situations using a combination of behavioural experiments and cognitive therapy. And it was really important to challenge his beliefs that alcohol helped him talk to women by examining whether that was actually the case when we considered the memory loss and the embarrassment and potentially the effect of alcohol on whether he was able to form relationships. And he also tested out in behavioural experiments the belief that he couldn't talk to the opposite sex without a drink by attempting this sober, with starting with people that he found less difficult to interact with and then building up as his confidence increased over time. So if you're interested in accessing this treatment, we have a paper in cognitive and behavioural practice, which describes the treatment in detail and also provides case vignettes about the application. And I'm also very happy to send you, we have therapist and client workbooks. So if you would like copies of those, you can email me and I'm happy to send you those. So in terms of, though, I focused on social anxiety, in terms of just quickly integrated treatment for other types of co-occurring presentations, there is some developing evidence in other fields, which I've just summarised here for you. So co-occurring OCD and substance use, there's been one trial which has found some promising results of an integrated treatment package. Co-occurring panic disorder and alcohol use, again, there's only been one trial, but some promising results. And I guess where there's the most evidence is for co-occurring PTSD and substance use, where there's been a number of trials that have now shown that integrated treatment appears to have some benefits over just focusing on the substance on its own. But if you are interested in managing co-occurring mental health disorders in the context of drug and alcohol disorders, I would refer you to the Comorbidity Guidelines website, which really has a lot of information about approaches across a number of different disorders that you see I've listed here. There are clinical practice guidelines for managing these disorders in the context of AOD, but there's also an online training program that you can go through. You can sort of pick and choose which bits are most relevant to you, but if you do the entire program, you can also get a certificate for your professional development as well. So it's a really great resource for looking at resources for other presentations, if that's of use to you. Okay, so we're on the home run. So I'm going to talk now, just I'll keep it brief because in the interest of time, about how we might intervene earlier on to prevent escalation of anxiety and alcohol use problems. And we know that for alcohol use disorders, there are really unacceptably long delays to seek treatment. The average is 18 years, which is really quite shocking. And I'm sure you've seen as well in clinical practice that by the time people reach you in treatment, they've often already experienced so much kind of life impairment and disruption to their work and their relationships and their quality of life. So what we really wanted to look at, I guess based on those experiences and that data, was what if we did something earlier on in the life course to kind of stop these problems becoming entrenched, given what we know about how anxiety and alcohol use tend to fuel each other. And so the period that we've identified as being really important is the late adolescent to early adulthood period, which we know is an important time for the development of both problems. But we also see these developmental links between anxiety and alcohol use really being evident at this point in time. So if you're a young person with anxiety, you're more likely to start using alcohol earlier. You're more likely to use alcohol to cope with your emotional symptoms, and you're also more likely to progress from occasional use to regular use to an alcohol use disorder. So getting in and addressing this link between anxiety and alcohol use early in that kind of late adolescent period could be a really good way of kind of preventing the chronic harms that we often see associated with these problems. But in addition to being a really high risk time, we also know that this is a really unique developmental phase where there's lots of different things going on for a young person. They're often, embarking on new living arrangements, moving out of home, or maybe not these days with the price of houses, but starting to think about moving out of home, new employment, new jobs, new relationships. And these are exciting things, but they can also be challenging for young people. And particularly if you're a young person who's prone to anxiety or has one of your coping styles is drinking to cope with your anxiety, it might be that the anxiety and the alcohol use difficulties can become even more pronounced across this transition to adulthood. And so given these particular needs and risks during this developmental stage, what we wanted to do was develop an intervention that was specifically tailored for youth. So we used as a starting point the program that I've just talked about before, the anxiety and alcohol treatment program, but we knew we needed to adapt it for young people in terms of the language, but also the situations that they're experiencing. Now, I'm someone who really believes in the benefits of, sitting down with a young person or sitting down with a client and working through things with them in the room. However, when we started to talk with young people about their preferences and looked at the research in terms of young people's preferences, what we really saw was that young people really like internet delivered treatment. And the reasons that they gave for this was that it's convenient, they can access it at 2 a.m. if they want a top up of skills at that point, or if they need help, or just some support at that time. They liked the anonymity that the internet provided, and they perceived that they had more control and that there was reduced stigma when they were accessing internet delivered treatment. And so the program that we developed is called the Inroads program, and it's an online program that has taken those core skills that we developed in our previous treatment program, but reduced it down to be a sort of shorter, briefer early intervention, but also added skills so that people were able to apply the anxiety management strategies across the board, so to address concerns relating to general anxiety and panic as well, if that was relevant to the young person. We developed it in consultation with young people, and so this helped us to include a number of features to make it more engaging for young people, so interactive features, videos, and also vignettes. And so it's a 5-module program, but we also, in addition to the internet components, we also included some therapist support. So people were provided with phone or email, had their own dedicated psychologist, and they were provided with 2 phone sessions as well as weekly email support from that psychologist. So it was a combination of the internet program plus the therapist support as well. And this is just some of the engaging features that we included, so including videos and little things for them to fill out, quizzes as well. And our trial took place between 2017 and 2019, and we had about 123 young people from all over Australia participate in the trial. Another advantage of it being online is that we can offer it to anyone in Australia, including in regional areas where they may not have a lot of access to services. And we followed up first of all, we randomly allocated participants to either get the Inroads program or a control condition which just receives some information about alcohol guidelines and recommendations for safe drinking, some information about the harms associated with alcohol. And then we followed up both groups at 2 months and 6 months to see how they were going. So in terms of the results, again, similar to our other trial, we saw a pretty clear pattern where anxiety symptoms were reducing more in the Inroads condition compared to the alcohol information condition. So the Inroads condition is here in the blue. And we saw that reduction took place immediately. So it took, by 2 months, we were already seeing that difference in the group. However, when we looked at alcohol, what we saw was that both groups reduced immediately, but the benefits of the Inroads program was seen later on. So by 6-month follow-up, what we were tending to see was a rebound effect in the control group. So it was like they were able to reduce their drinking somewhat initially, but they weren't able to sustain it. So the Inroads program helped them, help the participants to sustain their drinking gains over a longer period of time. And I guess this makes sense because we were also providing them with strategies to manage their anxiety, which I think would have helped them to be able to sustain those reductions in their drinking. So in conclusion, the Inroads program improved people's anxiety first. So it did that early on, but there were benefits for alcohol in the longer term. So by 6 months, we saw a relapse to drinking in the control group, whereas the Inroads group had a capacity to sustain the drinking reductions. And in the Inroads group, by 6-month follow-up, we saw that they'd been able to reduce their drinking on average by 62 standard drinks per month. So visually, that's quite a big reduction in terms of the amount of drinks they were able to cut out of their life, I guess. So I guess I'm running out of time, so just to quickly talk about where to next. We did this trial between 2017 and we finished it in 2019, and then of course COVID happened. And we know that the COVID pandemic has had some impacts on people's mental health, particularly among young people. We're seeing increasing anxiety and stress. We're also seeing 70% of Australians reporting higher alcohol consumption in some studies and reporting that this is linked to the increased stress that they're experiencing. So what we immediately thought was that the internet-delivered format of the Inroads program is potentially quite beneficial during the COVID pandemic, where we're seeing that, potentially you're in a lockdown period where people aren't able to access services, but also there are long waiting lists at the moment to seek psychological support. So an internet-delivered therapy that helps young people with anxiety and alcohol use might be really helpful, particularly at the moment. So we were able to secure some funding from the Department of Health to adapt the Inroads program. We adapted it in 2 ways. We adapted the content to include some vignettes and some strategies to help people specifically with the things they might be going through during the COVID pandemic. And then we also adapted it to include responsive auto messaging in place of the psychologist involvement, so that we could roll it out without requiring that psychologist support component, which would enable us to roll it out more broadly. And so we're currently offering this as part of a trial to people. It's available for anyone aged between 17 and 30 living in Australia who has anxiety symptoms and is also drinking above recommended guidelines. And it could be that you refer someone to the program to do the program in a self-directed way, or alternatively, because there is no psychologist component in this version of the program, you might be seeing a person yourself, a young person yourself, and refer them to the program to be able to kind of learn some additional skills to complement the work that you're doing with them. So if you have anyone who's interested, I encourage you to look at our website, inroads.org.au, to find out more or potentially register, and do contact us if you have any questions. So in a nutshell, I guess my take-home messages are, it's really important that we ask about anxiety and the link with alcohol use. It's really important that we motivate people to change by developing a mutual understanding of that interrelationship, and that we enhance people's coping strategies for both anxiety, alcohol, but also in terms of managing the interconnection between them. So thank you, just to acknowledge my co-authors and also funders. And I believe we might have time. I've left 2 minutes for some questions.
Thank you very much for generously sharing your work and the work of the Matilda Centre there. It's brilliant that we have these organisations that support bringing together researchers and then actually, putting that on the ground and doing trials to see how things work. And so we really appreciate your time in sharing that. And yes, we do have some questions. And yes, we'll try your camera on, and hopefully we'll...
I'll try, yeah.
That's great. I think that's always helpful. Thank you. You've been really, really patient with it all today. Thank you. So a few questions, and we'll see how many we get through. Just wanted to, one of the questions that came up fairly early on in your presentation was just around, and because you've had your head in this game, are you noticing any of the same types of prevalence and links and patterns for people who might have other substance use conditions or disorders?
Yeah, definitely. So it's really strong with alcohol, particularly social anxiety and alcohol use. I feel like that's in some ways the quintessential, because social contexts, alcohol is just everywhere. So the relationship is really strong for alcohol, but we certainly do see it for other substances, really across the board. And so I guess in terms of our next directions, we did exclude people that had dependence on other substances from our trials, just so that we could focus cleanly on alcohol in this trial. But in our future work, what we want to do is look at making the substance use skills more trans-diagnostic, I guess, so that they can be applied across multiple substances, knowing that people often have multiple substances as well. Yeah.
No, that's great. Thank you for that. Next question comes around pharmacotherapy, I guess, so medication. And I know you mentioned that during the trial, people had option to alcohol management. And I'm assuming that's kind of like withdrawal management and cravings management type medication. So I think this question might be about potentially medication for anxiety. It's a bit of an assumption there. Just asking about, are you aware of any ways or tools that can be applied for a clinician to be able to make a recommendation for somebody who might require, I guess, adjunct medication in the support of their treatment or change? Or just from your experience, was there a role for that?
Yeah, well, I guess if we're talking about anxiety or alcohol, and sorry, I should have mentioned that people in our trial could have been on antidepressants as well. So again, that wasn't an exclusion criteria for us. Some people are. What we tend to see in the anxiety literature is that psychological therapy is a treatment of choice. There may be some advantages of combining with medication treatment, as you say, but certainly for anxiety, psychological treatments are very good. So actually getting people to develop strategies that they can continue to apply and really make changes in their life. So I guess I would encourage, not being a psychiatrist myself, I would just encourage people to refer for a medical review. So this is for the alcohol. We did this as well. We referred our patients for a full medical review to determine determine whether pharmacotherapy was going to be helpful for the person. But it is important to consider, particularly for the dependents.
Sure. So not necessarily specific to it all, but certainly that multidisciplinary approach to have those reviews undertaken to see. Yeah. No,
and really important for, sorry, I'm glad you raised that because it's really important for withdrawal management as well. So we know in the case of alcohol that we have to be really careful about some clients might be at risk of complicated withdrawal if they are reducing their alcohol use too quickly. So it is really important to, at high levels of use, to have that medical support.
Sure. No, thank you for that. And I probably should have mentioned before starting off these questions, there's been a lot of comments about thanking you for this and thanking you for the research and also how interesting it is. The next question comes from somebody who is an Aboriginal works in an Aboriginal and Torres Strait Islander organisation. Now, I know that your topic is anxiety, and this is kind of around issues of trauma, and in particular intergenerational trauma. That the cohort there being difficult to work with. Just wondering from your experience, were there any engagement strategies that you used in particular, or would you have any suggestions around that process to help people, I guess, engage and remain in treatment?
Yeah, look, this is a complex population, like you say. So we were really happy. You saw that our treatment retention rates were about 70% for the integrated treatment, which we were really, really happy with, knowing that often it's a lot lower, particularly in substance use services. I think one of the big things, and we weren't addressing trauma at all. So the types of anxiety that we were focusing on, well, obviously with social anxiety and not trauma specifically. But I guess what I would say is that I think that addressing the integration between the two problems really helped in retaining people. So like I said, I feel like that's a better fit with people's experience generally. And so they're sort of relieved when you're not inviting them in and telling them to stop their drinking without giving them tools to manage those other things that are going on, and without kind of acknowledging, it makes sense that you're struggling to cut down on your alcohol use because you've got, and in the case of Aboriginal and Torres Strait Islander people, you've got this intergenerational trauma that you're sort of carrying with you. So really acknowledging and being present with that and having it as part of the focus of treatment. But yeah, I feel what you're saying, because it can be really tough.
Yeah, and thank you for our participant who sent that question in, because I think it's an important thing to raise. And you yourself also reflected on the fact that, because my background is working with substance use and trauma in an integrated way, because it is also another one of those ones that if you don't work with both, the PTSD can get worse, like you mentioned with social anxiety as well. And I'm still not sure, and I won't ask you this question, but I'm still not sure why we still have barriers to getting those kind of integrated approaches. And despite the fact that some of the evidence you quoted was from back in early 2000s, 20 years ago, that we were looking at this as well.
I think the quick answer to that is it's systemic, right? Because I know, like your audience, a lot of people that I talk to are really, people know that we need to, this isn't rocket science, right? You in practice know you need to help people with both problems, but it's just the way the systems are structured at the moment is so divided. So yeah.
Yes, I liked your term comorbidity roundabout, so I might appropriate that if that's okay. Just another question from somebody who was attending today, who provides support groups for people who are managing or dealing with alcohol or in the recovery from alcohol use issues, just around one of the things, I think, as it was mentioned in your program, that there's an encouragement to continue to engage in social environments and social activities. So things like parties and going out to venues or licensed premises and things like that. I just generally, the anecdotal experience of the questioner was that that tends to set people up for, potential setbacks. So just wondering if you could speak a little bit more about that and how that's kind of managed within your program.
Yeah, it's a really great question, because I did say, in contrast to some kind of traditional alcohol management approaches where you would say, yeah, avoid those triggers, those kind of really high risk triggers, which we would certainly do that initially. So, you know, we're not meeting people and in session one sending them off to a party that's going to have alcohol and, you know, but it's really about building them up slowly. So they would start engaging in socializing sober in really safe environments, like a cafe where there's no likelihood of alcohol, but then build up slowly to more and more challenging environments that may include some venues where there is going to be alcohol. And sometimes what we did, and I guess the idea is that you've built them up with other coping skills so that they're increasingly able to manage those situations. Sometimes what we actually did was in vivo behavioural experiments with clients where the therapist would go with them. So we'd actually go with them and they would practice ordering a non-alcoholic drink, because even that is challenging for people that have a long history of drinking. How do I ask for a non-alcoholic drink? How do I even do that? So yeah, so I guess it really is about, I understand the concerns and I think they're very valid, and thank you for asking those questions. But the approach that we took was that we could build people up slowly, knowing of course that sometimes things will go wrong as well, but then we manage that in the therapeutic relationship.
No, that's great. I imagine that was in the context of a CBT approach with building up very strong behavioural experiments with clear goals and actions and activities and predictions, I guess, around what was going to happen and what. Yeah.
Exactly, a really clear kind of step ladder, approach to how we would approach those situations, moving up to the highest, most difficult one, which might be, an environment where alcohol is served.
Sure. Just got probably a very specific question about the actual content of the intervention, the 10-week intervention.
Yeah.
So as part of dealing with people approaching high-risk situations, in the psycho-edge component, did you incorporate things like polyvagal theory and that type of thing, or any particular approach that was used in providing that?
No, we didn't. I mean, one thing that we struggled with was, like I showed you the slide where we have the evidence base for social anxiety, the evidence base for alcohol, and we're trying to integrate them both. And we did some consultation about like how many sessions can we, because optimally maybe you'd go for 20 sessions when you're trying to integrate treatment for two different approaches. But the feedback we got was we have to make it 10. We have to keep it brief and kind of feasible as well. So it was a challenge to integrate the different techniques. And I guess what we tried to go for, knowing also that evidence I talked about, where having multiple targets of therapy can be kind of confusing and overwhelming for clients, we tried to keep the psychoeducation as simple as possible, just a kind of simple messaging that we would reinforce over the course of therapy. So no, we didn't. It's an interesting point though.
That's all right. No, that's great. Thank you. And probably just a question from me. Was this a group or individual or a combined?
No, individual.
Individual.
Yeah. Okay. I probably rushed through it. I apologies to everyone for rushing a little bit. I was aware of catching up on time. Yes, it was individual.
Oh, look, I think you've done brilliantly, managed in a difficult situation today. And thank you again to our people who have tuned in. There was just one further question that about the websites, but I'm guessing that all the websites that you mentioned and the contact details are up on that current slide that's being shown on the screen at the moment.
Yes, that's right. So if people are interested in the youth program, inroads.org.au, all of the information about that program is on that website.